Hello, Mrs. X is a 65-year-old Caucasian female coming in today complaining of severe wheezing, shortness of breath, and cough. She reports feeling like she can't catch her breath. She did self-administer albuterol prior to coming in and stated that it gave her no relief. She reports frequent asthma exacerbations for the last 2 months, occurring more than 4 times a week. Of note, she was in a serious motor vehicle accident approximately 10 weeks ago. Her past medical history includes mild asthma since her 20s and mild CHF. She is currently taking an albuterol inhaler as needed, enalapril 5 milligrams daily, and hydrochlorothiazide 40 milligrams daily. She has no known allergies. She does have a positive family history of her mother and father both passing at a young age due to cardiac complications. She does have, for her social history, she is a non-smoker. She follows a low sodium diet and does report drinking 4 coffees, 4 Diet Cokes a day. Her review of symptoms is negative except for the respiratory complaints, and those are, she states she's got a cough that is occasionally productive with white yellow sputum, shortness of breath, and wheezing. She denies any cardiovascular symptoms such as chest pain and denies any other issues like throat pain. Her vitals reveal she's hypertensive at 160/90. She's tachycardic at 105 beats per minute. She is hypoxic at 90% on room air, and she is tachypnic at 24 breaths per minute. Her temp is slightly elevated at 99.8. On physical exam, she is alert and oriented ×3. She is overweight, pale, speaking in 2 to 3 word sentences, coughing and audibly wheezing. Her HEENT exam reveals mild inflammation of the posterior pharynx. Her cardiovascular exam is negative. There is no peripheral edema, no cyanosis or pallor noted. Her respiratory exam reveals inspiratory and expiratory wheezing, as well as retractions. And her PEF FEV1 is less than 40% of predicted. So the assessment of this patient is she is in respiratory distress. She is hypoxic, having retractions, speaking in short sentences, wheezing. Depending on the setting, she may need to be transferred to the emergency department in order to complete her full workup and to initiate treatments. The differential diagnoses that I'm thinking of in this situation, the first one being severe asthma exacerbation due to, it would be severe due to the peak flow measurements. With her history and her presentation, it is fitting. The treatment would include administration of a nebulizer, supplemental oxygen, and starting on a corticosteroid. I'm also thinking with her history of CHF that this could be a CHF exacerbation. Less likely based on the exam. There's no crackles upon auscultation. There's no edema noted on exam. We'll evaluate this in the workup, and treatment would include starting her on a diuretic. Also considering a viral or bacterial infection due to the respiratory symptoms, the productive cough, and the low-grade fever. We will look for this in the workup and treat with antibiotics or antivirals if needed. Also want to rule out any pulmonary embolism. She was in the previous motor vehicle accident, so we will work this up as well. If she was positive for that, she would require admission and anticoagulation. The treatment plan for her, I would begin her on a duo nebulizer treatment if available and place her on supplemental oxygen, titrating her oxygen level up to 93 to 95%. I would also begin corticosteroid treatment, and that would be prednisone 60 milligrams orally. Her workup would include EKG, chest x-ray, labs that include a CBC, CMP, troponin, BNP, D-dimer, and a point-of-care glucose. I would also add a sputum culture and nasal swabs to do viral testing. If she improved with the initial treatment and the workup supported an asthma exacerbation, would send her home on prednisone 40 milligrams for 5 days. She would also need to begin a more long-acting inhaler such as Symbicort, which would be 2 inhalations twice a day. And that's a combination of a LABA and a steroid. And then she would also continue her short-acting beta agonist, the albuterol, as needed. I would add in treatment with antibiotics or antivirals if needed in the workup. I would want to reassess her blood pressure, making sure that it improved when her symptoms improved. Otherwise, she may need titration of her blood pressure medications. With her family history, we would need close monitoring of that. we would also want to refer her to a pulmonologist for further workup and management of her symptoms, make sure that this treatment is working for her, see if there's anything else she needs, also possibly evaluate for a new diagnosis of COPD, and she would require close follow-up with her primary care doctor as well. Thank you.